I'm Dr. Megan Ritchie. I'm a palliative care specialist based at Concord Repatriation Hospital. I have an interest in fatigue management of our patients, including in research. And to begin with, I'd like to acknowledge the traditional custodians of the various lands from which our attendees join us today. And we pay our respects to elders past and present here at Concord Hospital, where with the Wangal people of the Great Eora Nation. Please be aware that this seminar has been recorded, so we request that you keep your microphones on mute during the presentation. If you have questions, please put them into the chat and we will respond to them all at the end. So this is now the 5th seminar in Cancer Symptom Trials Facing Fatigue series, and we thank those who have come to each session. For those that are new here, Cancer Symptoms Trials recently completed a Delphi study in adult cancer symptom research priorities in Australia and Aotearoa, New Zealand. Both consumers and healthcare professionals reported that fatigue was a symptom that was most troublesome, and I think we see that so much in clinical practice. Drawing on the Delphi study and given its relationship to other cancer symptoms as well as its universal presence, we believe that fatigue should be a high priority for further clinical research. So our speaker today is Dr. Carolina Sandler. Thank you so much for being our guest presenter today. It's very exciting. Carolina is an accredited exercise physiologist and clinical researcher. Her program of research focuses on understanding the pathophysiology and management of fatigue, incorporating physical activity and multidisciplinary interventions. She also focuses on clinician and patient education about fatigue resulting from cancer, so post-cancer fatigue, and acute infections or post-infective fatigue. Carolina holds a New South Wales Cancer Institute Early Career Fellowship and is a lecturer at Western Sydney University. She is also an adjunct researcher at the University of New South Wales Fatigue Clinic, the Menzies Health Institute at Griffith University, and the University of Queensland. Carolina's topic today is Principles of Management, Assessment of Activity, Pacing Threshold, and Graded Exercise Therapy. So thank you so much, Carolina, for presenting to us today, and we will have so much to learn from you. And I'll hand over for you to start sharing.
Thank you so much for having me. I'm just going to make sure I share my screen. Okay, well, thanks everyone for coming, and thank you for inviting me to present. It's really nice to be connected to other people who are interested in fatigue in the cancer context. So I'm just going to briefly go through a bit of an overview today. First of all, just briefly talking about some of the considerations when we talk about fatigue in cancer, and the differences between cancer-related fatigue and post-cancer fatigue, and then how that fatigue should be managed, particularly focusing on principles of activity pacing and graded exercise therapy, which is my specialty since I'm an exercise physiologist clinically. And then I'm going to be adapting some of the evidence and experiences in the post-cancer fatigue context and adapting it to the palliative care setting with a very short example, and also an example of during treatment as well. So obviously, like Megan just said, we've got we know that fatigue is a really important and a very common symptom, both during treatment and for some people also post-treatment. And patients not only are describing a physical fatigue where their limbs might feel quite heavy or maybe even feeling like weakness, but they also talk about a cognitive or mental fatigue where they have difficulty sustaining tough mental tasks. And what's really important is that because fatigue is an experience that we all have experienced before, it's important to distinguish between what's, everyday background fatigue and that fatigue that's problematic, that actually interrupts people's function, that limits their day-to-day activities of daily living. And also if the fatigue is transient, so if it lasts a few hours or days, as opposed to weeks or months. And really importantly, I think, is that investigating other causes or contributing factors to fatigue. So that might mean if someone's receiving treatment, for example, chemotherapy, or if they have comorbid conditions like anemia or depression or major depression, where it might be a cause of fatigue or it might be an exacerbator or a contributor to fatigue. And investigating those causes of fatigue and those contributing factors is really important, particularly so to make sure that the medical team's involved, so that basically we can treat what we're able to treat what we actually can, medically speaking. So I feel like everyone here would probably already know this, but what is cancer-related fatigue? It's this distressing, persistent, and subjective sensation of physical, emotional, or cognitive tiredness. And it's not proportional to any recent change in activity. And of course, it usually interrupts usual functioning. And you've got here, of course, a whole host of symptoms, physical symptoms, cognitive symptoms, difficulties concentrating with attention, with memory. Sometimes people will call this chemo fog. Also very common is sleep disturbances, so waking unrefreshed or having changes in sleep-wake cycles. But a symptom I particularly want to draw your attention to is what's called post-exertional malaise, or we would call it a post-exertional exacerbation of fatigue. And that's where patients experience a large exacerbation in their symptoms after a relatively small amount of activity. And that activity can be physical or cognitive. And this reaction to activity is what's really key to informing our management strategies, and particularly with exercise prescription, because we want to be very careful not to be prescribing too much exercise where that's going to be exacerbating symptoms. Probably just a note here in terms of this definition is it doesn't really distinguish between patients who are on treatment or off treatment, those who have advanced cancers or in palliative care. And it also doesn't mention anything about other causes or contributors to fatigue. So just want that to be something to highlight, because I'll come back to this later. So just to spend a little bit more time on that really hallmark key symptom of post-exertional malaise, or that post-exertional exacerbation of fatigue. This is an experimental study that we've conducted in patients with chronic fatigue states. And we asked them in a laboratory setting to complete a cognitive challenge, which was a driving simulator test, where they actually had to deliver a pizza and drive on the other side of the road. So very cognitively challenging activity. And then also an equivalent in a physical challenge where they rode on a stationary cycle for 25 minutes. And we compared patients with control participants. So both these graphs are presented in a similar way, where the patients are in the black circles and the control participants are in the open squares. And along the horizontal axis are the different time points that we've measured fatigue. So at baseline and before and after the challenge at several time points. And the red line that you can see is just to give you an idea of relative to baseline. So basically the story is the same in both of these challenge studies, where there's a difference, as we would expect, at baseline between patients and controls. But more importantly, that the control participants after the challenge return to their baseline levels of fatigue much quicker than patients. And it's the FES, the fatigue and energy scale, is how we record fatigue in this context. And it was actually able to capture this difference. So not only the difference between the participants and the patients, but also the increase in symptoms. And what you can see is that for some patients, even 24 hours later, their symptoms still haven't returned to baseline. Now, this is group data, so it's all of the participants together. And what you can see when you look at the individual data is that some patients have this exacerbation in fatigue in a delayed fashion. So they do the activity and they feel okay, but then 24 and sometimes even 48 hours later is when they experience that exacerbation. So it's just such an important key hallmark symptom that's often experienced in fatigue states that I think it's very important to be mindful when we're discussing management strategies and activity pacing, and particularly exercise. So in terms of the natural history, this is just some data from a prospective cohort study called the FOLCAN study, led by David Goldstein. And this was conducted in women with early stage breast cancer. And what they did was assess patients for clinically significant levels of fatigue. So that's fatigue that's bad enough that interrupts their daily function at various time points throughout their treatment. So along the x-axis are the different time points. So, so it says post-surgery, there's actually 1 month post-surgery. End of treatment, 3 months, 6 months, and 12 months. And then along the y-axis is the proportion of patients with debilitating fatigue. And what we can see is that at the end of treatment, so usually post, in this context for breast cancer, post-chemotherapy and radiotherapy, there's a large proportion, about 42% of patients who are reporting high levels of fatigue. But the good news is that by about 3 months, the majority of these patients, their fatigue has resolved. But there still are an important subset of patients that have this persistent fatigue following treatment. It's about 10 to 15%. And interestingly, in this study, they found no factors associated with, so no demographic factors or type of surgery or type of treatment that was a predictor of developing post-cancer fatigue. But experiencing fatigue during treatment was the predictor of experiencing fatigue post-treatment. Oh, too far. So what the investigators were very careful to do in that natural history study was to stick to a very strict definition of cancer-related fatigue, which is what I showed you earlier, but also to carefully delineate between those who were receiving treatment, which they called cancer-related fatigue, opposed to those who were finished treatment and that had persistent fatigues even after treatment had finished. And really importantly, there were no other medical explanations for their fatigue. So there was no thyroid dysfunction, there was no anemia, there was no other conditions that really could explain the fatigue. And sometimes in the literature, particularly in the exercise and cancer literature, the studies can be a little bit loose in their definition, not only of fatigue, but also understanding different contributing factors. And so we just need to look at that in detail when we are trying to understand what kind of interventions might be helpful. So, of course, depending on where people are in this natural history trajectory, if they're on treatment or off treatment, and that symptom of post-exertional malaise, is our exercise prescription and our management strategies will really vary. So it's quite timely because the American Society of Clinical Oncology just updated their guidelines very recently, and they conducted an evidence-based review of 113 randomized controlled trials for a whole host of interventions for fatigue during cancer. And this included things like exercise, cognitive behavioral therapy, mindfulness-based programs, dietary supplements, and pharmacological interventions. And they concluded that there was enough evidence to recommend, with different levels of strength, that during and after cancer treatment, there was good evidence for exercise, cognitive behavioral therapy, and mindfulness-based programs. And in the end-of-life context, they recommended cognitive behavioral therapy and corticosteroids. What I think they did really nicely as well is they really highlighted some of the challenges in the literature. So firstly, in terms of the sample that this evidence or this data comes from, it lacks quite a bit of diversity, which is not unique to fatigue. It happens a lot in research more broadly, where it's mostly Caucasian people who'd been investigated, women with breast cancer who were typically quite well and well educated. So we just need to be mindful about that when we're trying to translate this, I guess, into clinical practice. They also highlighted that many of the studies did not include fatigue as an entry point or an inclusion criteria to the study. So basically making it, patients are enrolled with a sub-threshold level of fatigue, making it challenging to observe any treatment effects because of the potential floor effect of it. And many studies didn't account for other explanations of fatigue, which I flagged before. And it could be due to cancer or the stage of cancer or the treatment or potential other conditions. So I think it's important to highlight that, we treat what we can. So the caveat to all this evidence and the information, and they say this in the ASCO guidelines, is that it all needs to be individualized, regardless of what intervention we're delivering. Individualized to the patient needs, to their ability, and to their context. So what does this look like in a management approach in real life? So the approach that we adapt in terms of management of fatigue states is that we typically distinguish between factors that initiate the illness, say like the cancer or the treatment, and then factors that propagate or make the illness worse, like having poor sleep-wake cycles, low mood, inappropriate levels of activity, for example. And all of these can lead to reduced physical, intellectual, and social function that eventually lead to disability. And so basically, the basis of our intervention is to target each of these elements, to interrupt the cycle of disability. So, for example, interrupting physical deconditioning using activity, pacing, and graded exercise therapy, or managing low mood and anxiety with cognitive behavioural therapies. Importantly, as an allied health professional, I'm really reliant and work closely with the medical team. So, for example, GPs or medical oncologists to assure us that some of these elements have been well assessed and well managed. So, for example, if there's uncontrolled pain, perhaps there's a role for analgesic relief, something that can really complement the management strategies. And I think importantly is the management of fatigue and these underlying principles, whether it's during treatment, post-treatment, or in end-of-life care, the principles are the same. And so I think we can still take from it depending on the patient context. So this figure is what we typically show patients when they first come through the clinic. And the cycle of disability that I just showed in the slide before can be particularly driven by inappropriate activity management. And what we typically see is when patients first come to the clinic, they say, you know, I've got some good days and I've got some bad days, and I find that my energy levels really fluctuate. And this is all related to that hallmark symptom of that post-exertional malaise or post-exertional exacerbation of fatigue. And so often patients say, I try and take advantage of the energy that I have when I've got it. And then the repercussion of that is an exacerbated symptoms and then reduced activity. So that's that boom bust pattern of activity that you can see on the far left of the graph. On the other hand, sometimes patients engage in what we call activity avoidance, where it's quite understandable if every time you go for a walk or you try and do some work, you have an exacerbation in your symptoms and you feel much worse. It's very understandable to pull right back and to avoid activity. And that's working, I guess, below your activity threshold. But then, of course, if we continuously do that, that leads to deconditioning as a consequence, which we'd like to avoid. So the aim initially is to identify different patterns of activity and how people are managing their energy levels, and then working within that optimal activity zone, which is that yellow activity pacing phase, and then moving on to the graded activity phase. And the graded activity phase includes graded exercise therapy, but also an equivalent in the cognitive space called what we call cognitive exercise therapy or cognitive retraining, sometimes the psychologists call it. And the whole management principle is all about thresholds, which I'll talk about in a minute. So knowing that the best available evidence comes from interventions of cognitive behavioural therapy and graded exercise therapy, we've combined these two treatment programs in this multidisciplinary program at the fatigue clinic. And the program's run by an exercise physiologist and a clinical psychologist and overseen by a specialist physician. And the clinicians work very closely together around the patient's needs. And then although it's a very modularized program, it's very individualized. So the purple rectangles here indicate the different modules that we might deliver to the patient, but these are specific to each individual. So for example, if anxiety is not a problem, then that module is just not delivered. Broadly speaking, everybody will have the focus of graded exercise therapy that the exercise physiologist delivers, and then the psychologist will deliver the equivalent of cognitive exercise therapy in the cognitive retraining program. And all of that is bridged through what we call activity pacing. So in terms of assessments, traditionally speaking, as an exercise physiologist, we like to measure a lot of things. We put people on bikes and do VO2 max testing and all that kind of stuff. But because fatigue is intrinsically a subjective symptom, it's actually not helpful to do those types of assessments. And it could potentially give rise to an exacerbation of symptoms, which is not what we want to do for patients, of course. So it's really all about subjective symptom report and understanding how the symptoms are interrupting people's day-to-day function and their activities of daily living. So we often would do a combination of a clinical interview, hand out or disseminate self-report questionnaires or patient-reported outcomes, and then as well, we do a one-off activity diary. And so the clinical interview, of course, will do a comprehensive medical assessment, understanding what kind of investigations has been conducted, understanding their treatment history, their current treatment status, etc. This self-report questionnaires are standardized and they're all validated. So we use them to help us understand what are the most pressing issues. So we assess things like fatigue, pain, mood, sleep. And depending on the scores that come out, it might help us organize what kind of modules we would deliver. And of course, we integrate that with our clinical interview to help individualize the intervention. And the diary for me is very helpful as well because it gives us a picture of how people are organizing their activities and, importantly, what their reaction is to activity. And not just physical activity, but their day-to-day activities. Are they doing laundry? Are they going to work? Are they running errands? Are they a carer for somebody? Are they doing the shopping? And how are they coping with that in terms of their symptoms and how they're organizing their activities within their threshold. So the first management strategy is called activity pacing, which I've mentioned a few times. And really how we describe this to the patients is that you've got one tank of energy. And the aim is to not run on empty, because when you run on empty, all your symptoms flare. And out of this tank of energy, all your type of activities come out of the same tank. Whether it's physical or cognitive or emotional, they come from the same tank. So by switching activities, so say you go for a walk and then you switch and you have a coffee with someone, that's actually still taking out of the same tank. And so what we really need to be mindful of is how do we not run on empty, which is easier said than done, but that's the principle of it, I guess. And so the first component of this, or the first type of pacing that we call micro pacing. And this is being aware of different task thresholds or limits. So what's a certain amount of time that a task of a particular intensity can be maintained before it will cause an exacerbation of symptoms or a bust in that boom-bust cycle, where your symptoms are worsened and as a result of doing too much. And what we encourage people to do is to break up the task into smaller blocks, followed by a structured rest, where you do complete physical and mental rest for at least 10 to 15 minutes. So an example of this, people might say, you know, I can read a book and I can read for about half an hour. And then about half an hour later, my eyes get really tired. I start to get a headache. I have to repeat the same sentence. I have to go read it again. And so for us, that's an indication that you've reached that threshold. So if that happened after half an hour, we'd encourage you to break that up into smaller tasks. That might look like doing it for 15 minutes, taking a structured rest, and then you can return and do another 15 minutes, for example, or you can switch tasks and do something else. And we apply that same kind of micro-pacing thresholds to physical, micro-pacing strategy, to physical activities as well as cognitive activities. The other type of pacing is more big picture planning, so what we call macro pacing. And this is organization of activities throughout the day, the week, and the month. And we say to patients that, you know, you've got a budget of energy that needs to last you, not only just what you're doing now, but also the day, the week, the month. And so we encourage patients not to book too many activities or too many errands or bookings, etc., on the same day or even on consecutive day. And so you can look at the example here that we've got from, this is a patient education snippet that activity that we sometimes give, where it's got a bunch of, you know, patient's schedule, let's say, or their diary, and it asks, you know, when would be an appropriate day to schedule lunch with a friend. And so on the day you've got an exam, it's probably not the best idea because we don't want to run on empty. So just kind of looking at the big picture rather than just day to day. And one way that we sometimes help people to conceptualize this is to get them to record their step count using an activity monitor, or their phone even. And this gives us a broad picture of how many steps are you doing day to day. with the goal of having some consistency in that to try and spread out your activity throughout the week. And it kind of gives you an idea of the budget of energy that you've got. And of course, being mindful that step counts only the physical activity, not the cognitive activity. So once we have people we've established what kind of activity pattern they're following, and then we've got them working within that optimal activity zone, then it's time to move on to some graded activity phase. And so in terms of graded exercise therapy, when I deliver this to exercise physiologists, I really hone in on that this is a different type of exercise prescription that we would typically give, because I know I sound like a broken record, but it's all about that post-exertional exacerbation and what's the patient's reaction to the exercise or the activity. It's really important that we are very conservative with our prescription so that we're not going to be contributing or making the fatigue worse. And how we conceptualize this in a clinical sense is, okay, if you do an activity, what's your reaction to it? If you have a flare in your symptoms, let's say your fatigue, that lasts an hour or less, then we feel that that's working within your threshold. If you go for a walk and you spend the rest of the afternoon on the couch, well, we might have overdone it. Now, it might not just be the walk, it could be other things that you've done during the day or during the week, but we just might need to reassess where we're at. So we need to choose an activity level that's appropriate, and we use very cautious, gradual increments. So this is a step-by-step of how we would normally prescribe exercise. And I feel like the first one's a no-brainer. I'm going to choose something that people are interested in, of course, otherwise they're not going to do it, you know. And also something that can be done regularly. So typically something of the similar time in terms of duration, similar intensity. So something like walking is a real common way to start this graded exercise program. So let's say, and then we figure out people's thresholds. So what is the threshold in terms of how long can you or should you walk for? And then how does that fit within your daily task, and how does that fit within your weekly task? And so that might mean starting like 10 minutes, for example, 3 days a week, so non-consecutive days, keeping in mind the macro pacing. And then we maintain that activity for at least 2 weeks, just to now allow enough time for people's bodies to adapt and to adjust to this new activity. And then we recommend increasing either the duration or the intensity, but not both. So just changing one variable at a time so we know what's working. And we generally find that an increase of 10 to 20% of duration is generally safe and achievable, but again, that'll be individualized. But we keep the intensity the same. So that's increasing a walk from 10 minutes to 12, for example. And we also encourage people to say that even if there are times where you're feeling like, I've got more energy, I really want to do more, we focus on trying to have consistency, because with consistency, we should have some more predictability in how you're feeling. So then in theory, after we gradually can develop this over time in a stepwise conservative fashion, and we can do the same in the cognitive exercise therapy, then we should have an increase in functional status of the patients. And it's quite good evidence for that. And so this is just some data from a randomized controlled trial I did for my PhD, where we randomized patients to receiving the intervention I just described or an education group. And we found that the intervention group had improvements in fatigue, but also in their self-reported physical function. It didn't cure the fatigue, it didn't make it go away. This is specifically in post-cancer fatigue, but it definitely had an improvement in function and their management of fatigue in terms of their symptom. So what I thought I'd just do in the last 10 minutes or so is just apply some of those principles of management in a different context, because I'm conscious that not everyone will have post-cancer fatigue. There will be people who are dealing with fatigue in different contexts. So this is actually a short case study that we wrote for a Seminars in Oncology Nursing journal. And so this particular one is a 55-year-old male with a recurrent glioblastoma. He'd undergone a tumour resection and was receiving radiotherapy, temozolomide and dexamethasone. His real struggle was with fatigue and deconditioning. He told us that he previously enjoyed gardening. So his main goals was to remain as independent as possible and wanted help with managing his fatigue. So when we assessed him, we found that he liked to take advantage of the energy that he had on the day. And so we captured that by getting him to record his step count. And we found that he'd have a day, for example, he'd do 4,000 steps and did lots. And then the next day he did about 1,000 steps. And so this is one objective way to capture that boom bust pattern of activity. And it's also helpful sometimes for patients to see that. So the plan was to do some pacing education, talk to him about some strategies, and initially just to focus on trying to stabilize that activity level by averaging a recommendation average of about 2,000 steps a day, just to try and develop some consistency in energy levels and fatigue. And then we implemented a home-based program, but it was to be performed on days that he didn't have treatment or he didn't have to go out for outings or other appointments. So it could be flexible depending on the week. And also encourage him to do some short walks down the driveway to the garden, do some sit to stand exercises to try and increase his strength, particularly his lower limb strength, and do some leg extensions. And by the end, initially he reported 8 out of 10 for fatigue, and it reduced to about a 6 out of 10. So with these management strategies, of course, we're not trying to make the fatigue disappear, but really trying to add some predictability, get people to feel like they have some control over their energy levels and their fatigue, even with some broad kind of strategies like step count. This example is a little bit more detailed just in terms of a cyclical nature. So I've chosen ovarian cancer because I was involved in a trial of exercise during treatment for ovarian cancer. And so this 63-year-old woman was receiving adjuvant chemotherapy in 3 weekly cycles. So in week 1, she received combination therapy of carboplatin and paclitaxel. And then in week 2 and 3, she received only paclitaxel. She reported already that having that cyclical pattern of fatigue exacerbation, where she found that it was mild in weeks 2 and 3 when it was just the paclitaxel, but felt that the fatigue was much more severe and debilitating in week 1 when she was receiving that combination therapy. And her symptoms were fatigue, nausea, joint pain, and she had some peripheral neuropathy in her hands. So hopefully this comes out okay in the little table up the top. So basically the first thing we did was just try to understand what did that fatigue look like during the week. And she received her chemotherapy on the Wednesday, and she often received steroids that day too. So the Thursday and Friday, she actually felt okay. And I've indicated that with little green smiley faces on top of Thursday and Friday. By Saturday, she said she started to feel a bit unwell. And by Sunday, she was quite unwell, housebound actually. By Saturday, starting to feel a little bit better, and then ready for Tuesday and Wednesday for her next chemotherapy cycle. And she did report, though, that on the days she was receiving the double dose, that she was unwell for about a week and a half. So again, trying to be a bit flexible depending on the situation. So in terms of the first type of activity or management strategy that we could do, we really tried to focus exercise to work around her scheduling of treatment. And so I've highlighted here in the red. So you might start working on her threshold, which is about 15 minutes on the Tuesday and Thursday. And you can see on the Saturday, I didn't make it a 15-minute walk, I made it a 10-minute walk. And that's just in anticipation of the fact that we know that typically on a Sunday, she's not going to be feeling so well. And really importantly, starting on non-consecutive days. Then we asked her to maintain those walks for a few weeks, and then we incorporated some strength training. And then about 3 or so weeks after that, then we increased the duration of the walks, but from 15 minutes to 17 minutes, and keeping the strength training program consistent. Importantly, we had a contingency plan. So how is she going to manage symptoms if she had a flare? Can she reduce the walks? Can she break the walks up into smaller chunks? Does she just let go of the strength training program for that particular week, etc.? Yeah, so basically, I just wanted to highlight how we could adapt some of those exercise prescription and management strategies within different contexts. And I hope I can highlight that just there are different considerations depending on the context of the patient. And I think it's really important that we're conscious of that. And that, of course, like lots of treatments or management strategies, it really needs to be individualized to the patient. I just wanted to acknowledge my collaborators and my findings. So thank you very much.
Thank you. Thank you so much, Carolina. That was incredibly informative. I know that I've taken a lot of notes and have a lot of reading to do. I'm going to start with some of the questions that are in the chat. First of all, we have a request for, is it possible to have a copy of the slides?
Sure, no worries.
Thank you very much. And so Jessie also has a question. Are there any activities to refill the energy tank other than rest, like activities that produce enjoyment and a restful experience?
Yes, that's a great question, because a rest sounds very simple to do, but we often say to patients in the clinic, it sounds easy, but it's actually really hard. It's really hard to do like nothing physically and nothing cognitively. And so often we go, okay, well, what can you do that's at least really low intensity? So it might be listening to music or flicking through a magazine, but it's not reading or anything like that. The enjoyable activities that are low intensity, we promote them because it's obviously really important to do things that we like, but it's not technically a rest. So people might like to read novels and they go, oh, I don't find it overly challenging, but it's not really a rest or just like a walk. So it doesn't mean that you shouldn't do it. It just means that it's not quite a rest. And so sometimes we would encourage people to go, can you do like a decent 10 to 15 minute proper rest and then do that activities that promote enjoyment or and can be restful. There's nothing wrong with doing that at all. But one way that we think about it in the clinic is that, you know, life is not as structured as I present in the pacing strategies. And so we pace when we can. And so that when other unexpected things come up, that we can kind of cope with them a little bit better. So hopefully that answers the question.
Yeah. Jessie, are you happy with the answer? Good, we'll move on. Vanessa asks, these are really good strategies for fatigue. As a long-term survivor, is a way you can disseminate to those who probably miss the regular clinical visits. I've tried to come to the fatigue clinic, but told that I was already doing all that the clinic would offer. But I think this information would be useful. So I tend to bust more often than not.
Yeah.
25 years.
So actually, Vanessa, that's the focus of my fellowship is to try and disseminate these resources in a different way. And so I can have a little think about a few things that I could disseminate. So if you want to flick me an email, I'm very happy to help you with that. I guess if, you know, we have sometimes people who come through the clinic more than once because maybe their life situation has changed, or they want to incorporate some exercise, or they want to just be reassured that they're doing the right thing, or they're struggling with something in particular. So I could definitely talk to you about that privately if you like. But one thing I'm trying to focus on is trying to make these resources available online for patients and also for GPs and also for allied health professionals, so that basically they can all work together to provide good care for people.
Thank you. Ryan has a question about the referral pathway to the fatigue clinic and how accessible these therapies will be for people from non-English speaking backgrounds, particularly the cognitive side of therapy.
Yeah, so the referral process is typically through the general practitioner, because we want to make sure that people have been well looked after and have ongoing continuity of care as well, because the program, I don't think I said this, but the program is about 18 weeks. And in terms of accessibility for people with non-English speaking backgrounds, I think it probably depends on the level of their understanding of the language and And yeah, so in terms of like, actually, do they speak English, and culturally, is it appropriate? So in terms of the cognitive side of things, really what we encourage patients to do is to choose their own activity. So the cognitive retraining, for example, we used a long time ago, used a program called Lumosity, which is like a brain training program, but that's just one example. People could do puzzles, or they could do crosswords, and that can be in any language. So as long as it's a challenging activity, but not one that's going to make things heaps worse, then that would be appropriate. And we could always negotiate or help discuss with the patient what that might look like.
Thank you. Our next question is from Alexia. When following the GET model, with increases in intensity every 2 weeks and the odd chance that fatigue is exacerbated, would you generally return to the baseline level or maintain that level until fatigue is managed?
Yeah. So I guess one thing I would do is, if a patient came to me and said, I just increased to 12 minutes from 10, for example, and I just felt real rubbish. So then, okay, what else is going on? So we'd look at the bigger picture. Let's say a uni student, did you have exams on? Did you have a cold? Did you get a cold? So then, maybe that made things worse as well. Or was the increase in exercise too much? And so that's probably the first thing to assess, just so that you can know maybe for next time, or what you might be able to change. But let's say it's just that the increase in duration was too much for that particular person. Typically speaking, we wouldn't go let's say we developed them up to say 20 minutes and they started at 10. I wouldn't always have to go back to 10. I would maybe bring it down to the increment before that. So let's say if it was 15 minutes, for example, or 18. When I would go back to baseline levels of exercise is if there's like a significant exacerbation. So that's something that's really lasted weeks. So that could be a new illness, it could be a particularly stressful time, or if there's going to be an increase in activity in other aspects of their life, but they want to maintain exercise. Okay, great. Let's just not increase exercise for a bit. Let's go back to your baseline so that you can maintain the routine, maintain that function. But because at the moment our focus is on moving house, or, whatever else might be going on, for example.
Fantastic. Thank you. We have another question here. How do you calculate rest time when pacing? In your example, if engaged in an activity for 15 minutes, how long is rest before restarting activity again?
Yeah, so we would recommend at least 10 to 15 if we can, before restarting. And often patients say, I feel like I'm spending more time resting than I am doing the activity. And sometimes it just takes a bit of practice, but often what people find is when they get to the end of the day, and of course they're tired because we all get tired, but maybe they're less fatigued than they normally would be, or that they can see by breaking things up and taking that 15-minute rest between activities, they can actually get more done throughout the day. Then usually that kind of positive feedback loop is people feeling good about that, and so they tend to engage in it more, but it's very tricky to do. But yeah, 15 minutes is what we would recommend.
Thank you. Another question from Vanessa. Do you find this different for children, adolescent, or young adults? And how do you manage changing levels of energy and societal expectations?
Yeah, it's a big one. So yeah, I think it's like any context, it's really about individualization about what's going on. We've had quite a few adolescents, and we don't want them to not go to the playground, or, not hang out with their friends, because actually it's so important to feel part of that community, and also important for like their mood and their social activity. And so we'd really just brainstorm, okay, how can we reduce the intensity of the activity? So it might even be like someone wants to do, I don't know, a dance class or something, and an hour dance class would be way too much. But we might do, okay, let's start with half of it and we will break it up into chunks. Or, okay, there's a social activity you want to go to on the weekend and it's going to push past your threshold. Let's just prepare for that. So it means the day before we need to try and conserve some energy. What else have you got going on? Just be prepared that the next day you will have an exacerbation in your fatigue, and that's okay, as long as you're prepared for it. And I guess occasionally it's okay to have an exacerbation of your fatigue, or your fatigue to be worse. We just don't want it to happen all the time, because it just it doesn't add predictability, it doesn't add consistency, and then of course that can just lead to that cycle of disability. So yes, it's very individualized, but yeah, tricky.
I had a question, and it was about the how you measure fatigue. I noticed, and what in your experience, what are your preferred measures and tools? I noticed in one of them you use a Sapir. What can you elaborate more on what you think is the best measure and tool? Because I struggle.
Yes. So there's lots of different tools that are out there. There are also cancer specific tools. We tend to not use cancer specific tools because fatigue's not a phenomenon that only happens in cancer. It happens in infection, it happens in neurological conditions like Parkinson's disease, stroke, lots of different contexts. So it's helpful for us to be able to compare levels of fatigue, levels of function, etc. So we always have a symptom assessment, and we have a disability assessment. So we've used the SF-36, for example, for disability. We've used the BDQ, brief disability questionnaire also. And in terms of fatigue, we use the Sphere because it's validated against clinical interview. And what's really nice about the Sphere, it has two prominent subscales, one called the SOMA, which is about fatigue, and one called the psych. And what that does is gives you caseness for clinically significant levels of fatigue and clinically significant levels of mood disturbance. Because that's often what fatigue scales don't do very well, is distinguish between fatigue because of mood and fatigue because of fatigue. And so, for example, we know that fatigue is a really common symptom in depression, but typically speaking, and I'm oversimplifying this, of course, fatigue in depression, the language might be, I don't have the motivation, it's really hard for me to find the motivation to do it. Fatigue in fatigue disorders is typically, I want to do things, I just don't have the energy. And teasing that out is important because we treat that differently. So that's why we like the Sphere, because it gives us that threshold. And Megan, I can send it to you if you like. And
that'd be great. Thank you.
And the other thing that we've developed actually is a structured clinical interview, which I nearly presented, but I didn't. And it's called the SKIN. So it's a structured clinical interview for neurasthenia. And it actually captures all the various components that comprise of fatigue. So sleep disturbance, cognitive, pain, mood disorder, fatigability, so prolonged fatigue after activity. And it comes up with like a composite score that helps us kind of tease out the cases from non-cases, etc. But I can share that with you too, Megan.
That would be fantastic. I'd be very interested to see that. I guess the next question is hard to interview and probably, again, on an individual basis, but particularly in the palliative care population, where it is unclear where people's primary complaint is fatigue, and their prognosis is not yet known. When do you switch from pacing and trying to pace to more of a complete energy conservation? Is it based off their palliative care phase, or is it more you try and give things a go and assess what the response is?
Yeah, so I mean, I feel like where they're in their palliative care phase is crucial, of course, because there will be fluctuations. And from the pacing perspective, I think it's really about management principles. So I think it can make a real difference to how people organize their lives, what they say yes to. But then on the other hand, the exercise component's important to try and maintain as much as possible in terms of function. And like you did flag, it will be an individualized response. And so I would even potentially focus, depending on, of course, the person, but focus on strength training as opposed to other types of exercise if I know that there's likely to be a significant decline soon. But number one is, what do they value? What's important to them? And we've had people who really want to do exercise because they said it's the only thing that I can control at the moment. Great, right? We can work around it. And so that might be several 2-minute walks in the day. It might be one longer walk, or it might be driving somewhere because they want that beautiful beach setting or whatever they've got, because I want that setting. So whatever we need to do to work around it, but trying to just add a bit of structure and I guess guidelines so they can feel in control of what is appropriate.
Thank you. Very helpful. Back to the chat again. We have some other questions. One from Vanessa. Thank you for the presentation and looking at getting referred to the fatigue clinic. And then also commenting that it can be difficult with people with or after cancer. They can have depression on top of their treatment symptoms and a combination of fatigue reasons, which is
yes. So I'm actually really glad Vanessa flagged that. So because I meant to mention it when we talked about that cycle of disability. Often even if mood disturbance isn't a primary cause of the fatigue, so let's say there's no major depression, is very typical, not just in fatigue disorders, but other chronic diseases, to have what we call secondary mood disturbance. So, I'm frustrated that I can't do the things I want to do. I'm starting to feel sorry for myself. I feel like I've lost confidence because I can't do X, Y, and Z. And so even though I've said, if there's other medical or psychiatric explanations, we wouldn't call that post-cancer fatigue. In real life, people don't exist in kind of silos, right? So it's very normal for those anxiety, those worries, that low mood to be part of the syndrome. And that's why it's an individualized intervention, because sometimes even by just pacing and people feeling in control of their symptoms, their mood improves. And sometimes they need more targeted intervention like CBT for mood or pharmacological interventions. But that conversation's always done with the patient and then always engaging their GP or whatever specialist they're seeing as well.
Thank you. There's a question from Alexia, thanking you for the presentation. Are there many other fatigue clinics that you know of around Melbourne? From my experience, there are many challenges for patients to access these services within the community. Yes.
So this is a real problem because there are no other fatigue clinics, but there is a wonderful clinic in Melbourne called the, oh my gosh, Active Health Clinic. I will definitely find it and post it on the chat. And it's run by a wonderful exercise physiologist called Nathan Butler. Got lots of experience in this field, and he doesn't have a multidisciplinary clinic like we do, but all his exercise physiologists specialize in fatigue states and other things, and often they refer to psychologists, for example, who specialize or have experience in this as well. So I can definitely send his details, his clinic details. And I guess the other thing is that the fatigue clinic since COVID, one good thing that came out of COVID is able to do, depending on the context, sometimes telemedicine. So it's also an option if needed. So
thank you. I'm just going to go to Ryan, who's got her hand up.
Thank you, Megan, and thank you, Carolina. This was a fantastic presentation. I've certainly learned a lot myself as someone who suffers from chronic fatigue due to a neurological condition. I just wanted to very quickly touch on the non-English speaking background population, given that this is the area that I am researching in. I guess we can no longer ignore the fact that Australia is rapidly growing in ethnic diversity, and language is often seen as a barrier, but I feel that we really need to shift that mindset, and it's a need that we need to meet. And so it's great that you've got these dissemination activities planned. I would suggest looking into perhaps translations or disseminating through community groups, consumer groups who work with cancer patients and survivors, as well as connecting with bilingual professionals. We have a lot of people in our community that are trained and accredited psychologists and exercise physiologists. So I think that would be a great way to disseminate through people who can improve that accessibility for people from non-English speaking background.
Yeah, I think it's really important. And I think that So I'm bilingual, I speak Spanish, and so that's been very helpful for, but it depends on the area that you live in, and particular groups are more prominent in different areas. So I think it's really important that we do that properly though, and that we consult with the right stakeholders so that it's not only language appropriate, but culturally appropriate.
Absolutely.
So we could definitely write a grant about that.
Yes, we can. Thank you.
Thank you. I think that was really fantastic. I have learned a lot, and I've got a lot of reading that I'm going to be doing after. So I really appreciate your expertise and attention to the questions. I've put 2 things into the chat. One is anyone who's interested in joining the fatigue node subcommittee in research. So you can please email and express an interest. And I've also put the web address where the recordings are available for the Facing Fatigue Committee. So I again thank you so much, Carolina, for talking to us today. It's incredibly valuable, and we appreciate your time. So thank you.
Thank you for having me. Lovely to meet you all.